I'm going to look at that when I get there. All right, bye.
See you, Chris. All right. So the previous episode we did on D4 bone drilling protocols and tips and tricks. And now we're gonna hop into D, what? Do you want to do D1 or and then do D2, D3?
Oh, yeah, that sounds good. We can start going through the
Okay.
actual drilling sequence now, I guess. That
Okay.
page.
And so the next episode is going to be D1 and then D2, D3 potentially. And we wrap up, we'll see if we covered everything. We'll try to keep it to 20 minutes and we'll try to knock out one or two, or we'll just do a slightly longer one and cover all the topics.
Yeah.
Here we go. Welcome back, everyone, to another episode of Surgical Saturdays. I'm Dr. Taher Dhoon, and we have Dr. Daniel Briskie from Colorado Surgical Institute. The last episode, we covered drilling protocols for D4 bone. I took a little tangent. I skipped over 1, 2, and 3 and went directly to 4. And so now we're going to circle back and we're going to start at D1 bone drilling protocols and how to kind of manage these things, because D4 is difficult. D1 is also difficult. And then your D2 and D3 is your kind of your bread and butter. So Dr. Briskie, you want to lead us off with thoughts on D1 drilling protocols? Assuming the flap is done, we're not going into that, and we're picking up our lance drill on this case.
Yeah, of course. So let's review a few things that we discussed on the last episode, which are really important principles, which is how to determine the bone density. And there's 3 things that we do at CSI that we stress importance on, which one of them is looking at the CT, right? Just look at it and say, hey, is this bone look extremely dark and looks like air? Or does it have some sort of opacity to the inside of the bone, right? So if it's only dark, probably D4. But if it's, has some sort of opaqueness to it, then it's D1, D2, D3. Then what we do for our drilling protocol is we do what's called more of a push test. And a push test is basically rocking your drill side to side while pushing apically. Now, if your drill does advance, again, that's another sign that you're probably in D4. But if it encounters some sort of resistance, then you're somewhere between D1 and D3, right? And then the third thing that we always recommend doing is when you are drilling, and you're drilling usually around 50-50. So 50-50 means you're going to be drilling at 50 RPMs at 50 Newton centimeters. So the burr is basically just winding down the bone. And if you drill like that with a 2 millimeter or even a 3.5, and then you take the burr out of the bone, literally you can see what type of bone it is based on what is on the threads of the drill. So I know that was always surprising when I first learned this. And it is actually very realistic. So if you drill in D1 bone and you have your 2 millimeter burr go down, or even a 3.5, and when you pull that burr out, it's going to have literally just white bone on it. If it's just white bone, you're in D1 bone. If you drill a hole and it's, if you're winding down the bone at 50 RPMs and 50 Newton centimeters, and you pull the burr out and it is really just blood on the drill, maybe like 10% bone, then you're in D4. And then if you're drilling down the bone and you see the flutes have a mixture of red and white bone, you're somewhere around D1 and D2. Or sorry, D2 and D3.
Okay, awesome.
So first let's talk as if we're just drilling a normal hole, right? And drilling a hole, we actually noticed that a lot of doctors in our classes for the past 3 years all do a very common mistake, and that is drilling to depth. So I would describe depth. The definition of depth for an implant is the implant size plus an additional 2 to 3 millimeters. Because what happens to a lot of doctors is they go to place a 10 millimeter implant and then you drill to a 10, right? But if you drill to a 10 and you're trying to place the implant 1 to 2 millimeters below the bone, the implant can bottom out at the bottom of the osteotomy. And if it's D1 bone, it literally just hits a rock wall. And when you're trying to put it in, the implant starts to spin. And then what we attribute that to is we say, oh man, this bone is actually really soft. It's not though. This is D1 or D2 bone. And what's happening is the implant threads are hitting a brick wall. And because it can't advance, it starts to spin.
Yeah, that used to catch me off guard. And when I do D1 bone, I always over drill the length of the osteotomy, with the caveat is that there's no vital structures underneath, right? I mean, of course, we're not going to say drill long and hit the IAN or drill long and, you know, obliterate the sinus or the nose. But at the same time, it's if you have an opportunity to drill long in D1, 2, or 3, 3 millimeters longer is a kind of a good rule of thumb, because you're going to place your implant 2 millimeters subcrestal, and then in certain circumstances, maybe 3 millimeters, but for the context of this conversation, 2 millimeters subcrestal. And so you're just giving yourself some space. So in the D1 bone, you pick up your lance drill, you run that at 2000 RPM, and you get your pilot down, or your little, you know, pilot down at least 6 to 8 millimeters, you know, whatever your comfort level is, and then take it out. What you may find is the drill will stop advancing while you're rotating at 2000 RPM, 1200 RPM, whatever your high speed protocol speed is. And then you have to take the drill out, and you just keep the drill rotating. But as it's rotating, the bone that's stuck to the drill, the flutes, the irrigant will like wash it off, or your assistant has to just kind of tap your drill with their suction to get the bone flakes to come off of it. Excuse me. So what that's going to do, and then you take your drill back in and you can advance your pilot even further. Then I'm done with my 1.5 drill. I'll pick up my Neodent 2.0 lance and I'll drop that sucker in, and I'll see how much further it advances. And you have to do a little dance where you go in for 2 seconds and then out, and let all the bone flakes kind of come out of the osteotomy, let all the bone flakes come off your drill, then advance that sucker back in. And then you can go up to your next drill, which is a 2.0 that has end cutting, but it's also lateral cutting as well. And then you can drop that sucker down. And then that one, you need it to go 3 millimeters past the length of the implant. So let's say in this example, we're placing a 13 millimeter implant. We're going to be drilling 16 millimeters with that 2.0 drill. And same thing, it has flutes where when you drive that sucker down in there, it may not go all the way. You'll take it out. You'll see all this white bone stuck in the flutes. And as your assistant taps on your drill, or your irrigant is hitting your drill, then the bone comes out of the flutes, and then you advance it further back in. If you're hitting a lot of resistance in your drilling, that typically means you're in pretty cortical bone, or you're hitting a cortical plate. So in the maxilla, the cortical plate could be the palate and your angulation is off. It could be the base of the nose. It could be the sinus, the antral floor. And so you want to be careful with over drilling and not knowing your measurements in the maxilla. But that's why we have a CBCT and we measure our surgeries ahead of time. In the mandible, in the posterior mandible, it's very common to hit the submandibular fossa, that little, you know, curvature that occurs for the space for the submandibular gland. And then in the anterior, it's just the angle of the mandible. Sometimes you're hitting a concavity. Other times you're just bottoming out on the lingual plate. Dr. Briskie, you want to talk about how you handle cortical plates and your drilling protocol? This next part is super important. And since I changed the way I drilled to the way Dr. Briskie is going to talk about, it has really upped my game, and it has significantly decreased the times I've had complications, and it's increased my ability to get my implant in the right spot, in the right space.
Yeah. So I have still in my career yet to perforate a lingual cortex. Still. Right? Like 600 arches later.
I still have many of them. I've perforated many, many times.
Yeah. So everyone listening, I used to say the same thing about sending a root tip through the sinus, but I actually did that about 2 weeks ago for the first time. So it was a little bit humbling, but we can always talk about that on a different episode. Yeah. So if you look at a CT and you plan an implant and there's a mile of bone, then let's be confident that we have no vital anatomy to injure, right? Let's just be confident about that right off the billing. So you can drill, you can place your implant, let's not worry. But there are a lot of cases where you take your case and you plan an implant on your number 19 or 20 side, or right, and where you have that submandibular fossa area, the area that you just really don't want to perforate, right? So what I do in these cases is first I use my 1.5 and 2. And before I go down with a 3-5, I'm deciding several things. First, I want my implant osteotomy to be in the exact location, mesial-distally and buccolingually, before I bring a burr down. So I'll take my 1.5 and I only go in 3 millimeters. And I really just make a 3 millimeter indentation with my 1.5, exactly where I want to go, right? And I check it, maybe even take an x-ray to make sure that you're exactly centered. Then if you're not, you change it and you make it centered. Then you grab your 2.0, and I do the same thing with a 2.0. I also redefine again at the top of where I am at the osteotomy, at the top of it, before I go down. So now that I'm reached the point where I like exactly where I should be with the 2.0, now I feel confident to bring the burr down the bone. So in the cases where I planned the implant and I'm worried about a vital structure, right, which is quite a few cases, I'll instantly bump my burr down to 50 Newton centimeters, or sorry, 50 RPMs at 50 Newton centimeters. So I actually won't drill fast at all after this one burr. And what you'll notice is if you rock the drill side to side while pushing apically, that burr will 100% go down the bone. Whether that's D1, D2, or D3, it will go down. But what you will have to do is what Dr. Dhoon said is, because that burr flutes will get caught with bone, you have to take the drill out and suction the bone off, or you wipe it with a gauze, or even save it, right? Save the bone and you can add it back later.
I was
So
gonna say, save it. I get a little like saline dish and I'll put the drill in there and I'll save the autogenous bone just in case I need it. And by the way, this 50-50 protocol he's gonna go into, I talked about at the GPS Summit just this past weekend. And it was something that no one has ever heard about. And people were like super intrigued and they're like, I'm going to go home and try this. This sounds amazing. So definitely like, this is the part I want everyone to listen to implement and try out when you get back to practice.
Yep. So if you're drilling 50-50 and this burr is just winding down, one, I promise you it will advance because it's advanced in every scenario that it's ever happened to me. So when you're drilling and it goes down, what will happen is if you're on the lingual cortex, the burr will literally just stop and you won't be able to advance it, because drilling 50 RPMs of 50 Newton centimeters is not fast enough to perforate that lingual cortex. It's only good enough to advance it up until it reaches that point. So you'll see your burr go down, it will winding down, and then it will stop. And you're like, oh, that's cool. It just stopped. And I've had so many cases where there's an hourglass mandible, and with an hourglass mandible and you're placing some long implants like 13s or 16s, it's important to stay in the center of the bone. So what will happen in those circumstances are my burr will be winding down and then it kind of stops. So when it stops, I know that it advanced to the point where it's hitting the cortex. And if you rock the drill side to side, you'll actually find where it will start to advance again, right? And that may mean that you may be change the angulation of that drill maybe 10 to 20 degrees. And then all of a sudden, it's being allowed to work its way back down the bone. So it's literally bouncing off the cortex and redirecting you while you're drilling. And I've been doing this way for, gosh, like 4 or 5 years now, actually 5 years now. And I have yet to perforate any lingual cortexes. And you can use the same strategy if you don't want to engage the bottom of the nose. Like if you're a little bit worried about engaging cortical bone on the bottom of the nose or perforating the sinus, this is a great tool to do that. Same thing with a number 3 or 4 implant. If you want to know how much bone you have, if you drill 50-50, your burr will stop at the sinus. And then you just take a check x-ray. So you take a check x-ray to make sure that you are there. And then you know how far to advance your next burr. But I promise you, like this is the safest way to drill. We had over all of our full arch classes over the past 3 years, I only remember 2 times where the lingual cortex was perforated. In both of those circumstances, both of those rooms were a thin mandible, and the doctor didn't drill slow like we advised. But I was actually able to redirect it while drilling 50-50. And the doctor was like, how the hell did you redirect my implant who's through the lingual cortex? And all I did was place pressure towards the buccal plate, and my burr would wind down the bone following the buccal bone, and it would redirect right down the smack dab in the middle.
Yeah, I love the 50-50 protocol. And when Dr. Briskie says the burr stops, just keep in mind it's still rotating, it's just not advancing further apically. And then let's say you're in the maxilla and you're kind of under the nose and you stop right at 11. Well, then you're going to place an implant 2 millimeters subcrestal. The cortical plate is probably 2-3 millimeters thick. So when you pop through the cortical plate and then you add in your 2 or 3 millimeters over there, so you got 13 now through the cortex, you're like, okay, well, I can place an 11.5 millimeter implant. I can place that 2 millimeters subcrestal. So that gives me 13.5 millimeters. And I'm going to have bicortical stabilization. So I'm going to have my implant apex in the base of the nose, but not so far in that it's going to create a chronic irritant, but just enough where I'm going to get a lot of stability. So if we're getting into, sinuses and noses, you can go 2 millimeters into them and engage them and not create a problem. Don't go 3, don't go 4, don't go 5, but 2 millimeters is adequate. So back to the drilling protocol, you're doing your 3-5 drill at 50-50. You take that in to depth, right? 3 millimeters past the length of your implant. Take the drill out, look at the burr, and then you assess again the quality of the bone. If it's all white bone, it's D1 bone. If it's white and red, it's D2. If it's more red than white, D3. And again, we already talked about D4. We don't have to talk about that. And then if you want, go ahead and you can place your 3-5 implant. If you want to place a 4-0 implant, maybe size up, maybe try placing your 4 implant. You can drill to a 3-5 and try a 4-0. So actually, let's go through this next part, this next series, and I'll just kind of talk through like my thought process. If you always want to achieve stability on your implants, it never hurts to under prep your osteotomy and then place an implant. So for example, I drilled to my 3-5, my 3-5 diameter drill. I pick up a 4-0 implant and I start placing it. If it's D1 and D2 and maybe sometimes D3 bone, it'll only go in halfway and it'll stop. So I place them at 50-50 for the context of what you guys do in private practice. Maybe try 30-30 in the very beginning and then play around with your speeds and your torque. But, let's say I place it at 30-30. You start placing that thing and it stops halfway out, put it in reverse, take it out, pick up your 4-0 drill and take that in only halfway. And then you take your same 4-0 implant and you start placing your 4-0 implant, and you'll see that thing go down about 80% of the way, and then it'll torque out. And then you drive the rest of it with your ratchet. Dr. Briskie, you want to take them through some of those thought processes in terms of now we're undersizing our osteotomy and we're going to place an implant. And how do we sequentially do this in a way that allows us to always have stability?
Yeah, of course. So let's talk about, for this scenario, let's say we're placing a 4-3 by 10 millimeter implant. Okay. So we're going to do our 1.5, then a 2, and then we're going to go down the bone now with a 3.5, right? So this is going to be a neodent 4.3 by 10. So a super common implant that we place. So after you take the 3.5 down to depth, remember depth is implant plus 3 millimeters when you can. So now we're at 13. The 3.75 drill I find is optional. So I actually skip over that one and I go right to the 4 millimeter drill. So now I'll put my 4 millimeter drill in and I'll take that one to depth. All right. And then I'll take and I'm drilling 50-50, right? And each time I'm drilling 50-50, like a couple of things can happen. If you're drilling slow like that, sometimes the burr literally just goes down to the depth and you don't even have to push, right? So what if this is a scenario? What if you're thinking that this bone is D1, but it's really D3, right? Like the inside of the bone or the apical portion. So this is why it's so important to push the burr while you're drilling slower at these points in times. Because I don't know how many times throughout me placing an implant that I misjudged the bone and I thought it was D1, but it was really D3. And then your drill just instantly goes to depth. You're like, oh, well, I actually don't have to drill then, right? That's going to be a sign that you should probably stop drilling and undersize your osteotomy, right? So there's little checkpoints along the way when you're drilling that will identify that maybe your judgment was wrong throughout this process. But let's say we're in D1, right, for this scenario. So now we did a 4.0, we went to depth, and if we're placing still a 4.3 by 10, you still need to drill with the 4.3. And I would go 4.3, and I would go put that into depth as well. Now, a Newton drill will undersize the osteotomy about, I think it's 0.7 to 1. So already on the drill itself. So this D1 bone, I take my last burr to depth, and then I place the implant. And in true D1 bone cases, that implant could actually stop halfway above the bone, and you took your last burr in. So for those scenarios, I would actually take the implant out, and I would drill with the 4.3 plus burr, which is 0.3 millimeters wider, or you can take your 5 millimeter burr in halfway. And then I would put the same implant back in. Now with D2 or D3 bone, what happens is, let's say we're at a 3.5 and we're at depth now with our burr. And then we go to take a 4 millimeter burr in, right? And we're placing a 4.3 by 10. So we're at the 4.0 drill now. And we're at a delicate area because we're deciding whether or not to drill with that 4, right? Because if you drill too much with that last burr, you won't get stability now. Now you have to either increase the size of the implant in terms of the diameter, or you're placing a longer implant, right, to get stability. So we do the same thing now. We put the 4 in, and then you start drilling 50-50, but you push at the same time, right? Now, if you're pushing and you're still getting so much resistance, you just let the burr do its thing and go down to depth and take it out, right? But at any point in time, you notice that burr is really starting to advance or slip. That means that bone is really soft. So at that point in time, I would stop drilling and put the implant in. Because what you don't want to do with implants is accidentally over drill.
Yep, I 100% agree. You can always drill more later. And so if you put your implant in and it bottoms out halfway, I think a good rule of thumb is to remove the implant. I like to fill up the container the implant comes in with saline and then put my implant in there. Some people like the PRF juice from when you kind of pressed your slug, and then they'll put their implant in there. It's just keep it hydrated. The last thing you want is bone and blood on your implant to dry or coagulate, and then to try to replace that implant later. So if you think the implant's going to sit for a few minutes, just make sure you keep it hydrated on the side. And then, yeah, then drill more. You can always drill more. And the beauty about the Neodent system is, again, the design of the implant, like we talked about on the last episode, is the first half of the implant is a self-tapping implant. And then it's a triangular cutting thread. And then the second half of the implant is trapezoidal and compressive. And so as that part of the implant goes in, you start feeling a lot of torque getting generated. And typically speaking, with this protocol, you're not going to have a spinner unless it's D4, D5 bone type of scenarios. Yeah. So let's say your implant is placed and it's 2 millimeters subcrestal, but I was driving it in and I got to about like a little bit over 60. Do you back it out and then bring it in so then it ends at 45? So you're kind of dissipating forces in the bone on your implant. And then can you also address the thought process behind pressure necrosis in single implant placements where the crest of the ridge is still present, and some of these like finishing techniques?
Yep, of course. So when we're bringing an implant down, a lot of the time what will happen is, especially throughout I remember my first 100 implants, I would put the implant in and it would stop at the bone and it would be 50. I'm like, oh my God, I got it, right? I got it. I got a successful implant. And then you try to put a torque wrench on it and then you can't get it to go down, right? There's two things you think about. First, I would, one, make sure that we are not okay then with something that's less than ideal, right? The implant has to be placed below the bone, right? Don't just leave it ever. because if you do, you will get bone loss on that implant and you'll be sorry that you left it there. So we already know if it stops at the bone and it has a high torque value, so it's at like 45, 50, 60, something like that, it has to go down the bone. So I would put a torque wrench on the implant. I would take the implant with a ratchet, and I would picture the ratchet as like a circle with 360 degrees. I would take half of that circle, which is like 180, and I would back it out twice. So 2 times reverse at 180 degrees. Then I would switch it back to where the implant's going to be going in the bone, and then you're going to torque it in the bone 3 times. So 2 turns out, 3 turns in. And you should be able to get that implant to start to go deeper. If it doesn't, don't muscle it in there. If you muscle an implant, you will break something. So you could break the implant, you could break the prosthetic parts, and it is a really bad day when you break a driver in an implant. So remember, just don't do that. So if you can't get it down, think about what's going on, right? What's going on is the implant is hitting a brick wall. So I would take the implant out, then I would check your depth. I bet you didn't drill deep enough. So I wish I would have done this more early in my career, which was take an implant out and identify what is the issue. And most of the time, it's actually the implant depth of that you didn't drill to that is the problem. So I'll go back in there, and then I would drill about another 2 to 3 millimeters deeper. Then you put the same exact implant back in, and I guarantee the implant will go down. Right? So what happens is pressure necrosis is a myth. And the reason it's a myth is if you put an implant at the bone, right? And an implant doesn't have any blood supply when it's at the crest because it has a thick cortical plate. Where it does survive is it needs blood around it in a circle. So if you place the implant 1 to 2 millimeters below the bone, there's blood in a circle, right? And now you don't get the pressure necrosis. Pressure necrosis happens not from really, per se, like the pressure at the top of it. It comes from the fact that there's no blood supply in cortical bone, is where it comes from. So when we're doing an implant, it's important to do, one is the depth, right? But also Dune started to allude to the stability of the implant. We want it below the bone, but we also want to be extra careful and have our implant at exactly 45. So let's say I'm placing my implant and I get it to be 1 to 2 below, and then I put a torque wrench on it and it's at 60 or 70, right? It's like it's very high torque. The last thing I would do, and this we give style points for this, is you unturn it, you back it out 1 millimeter, or you back it out 1 to 2 turns, and then you put it back in, but you allow the torque to read exactly 45. So you have style points now, right? You're putting it below the bone, but you're also making your implant exactly 45 Newton centimeters.
Now, keep in mind, if you're in the beginning of your journey with this, if you get a 35, that's fine. If you get a 30, it's probably okay, right? Put a healing abutment on it, you're okay. You start getting under a 30, you really want to start considering like cover screws, and then just your own experience in terms of how you make your judgment call on these. But at the end of the day, if you can drop your singles in and get to a 45, that's going to be ideal. You don't necessarily want to be above a 50, then you can back it out a little bit and drive it in and end on that 45, because that's going to be the ideal zone. Like Dr. Briskie talked about in the previous episode, then if you have that stability at a 45, you can switch out your healing abutments, you can immediately load it. It just opens up so many different options for you. Now, a few of the finishing points to remember, depending on the type of implant you're using, depending on how subcrestal that the manufacturer calls for, you may want to profile the bone. And they have bone profilers that come specific with these kits and implant kits. So then later down the road, your scan bodies and your impression copings and things can fit on your implant, so you don't have to do a second stage surgery. So consider doing all your surgical type of approaches on the first surgery, so you don't have to re-anesthetize the patient needlessly later down the road because you skipped a step. So ask your implant manufacturers about bone profilers. Neodent sells them separate. I just stocked up on a couple of them and I put them in all my kits. So I have it available for me if I ever need them. Two, I would say healing abutments over cover screws. Is that a general rule? Right?
Oh, 100%. Because like the biggest question is if you put an implant in and the stability is 20 or 25, does it heal? Well, the answer is yes, it will heal, but when? How long will it heal, right? And what's like an objective way to read when it is healed all the way? But if you have the ability and you put an implant in, it's 20 to 25, and you have the ability to do a better job, right? Which means just take the implant out. And if you can go one size wider or one size deeper, do that. Because for me, I don't want to be thinking about that implant when it's healing. So let's say you do a cover screw and your implant's at 25, right? And then your incision opens. So during healing, and I know everyone has this happen. You see this posted on Facebook all the time, where a doc says, "Hey, I placed an implant. We're at 1 month out, and I already have bone loss." Right? What usually is the scenario is the incision has opened up, and then there is a communication from the outside environment to the top of the implant. So bacteria and food are sitting on the top of the implant, causing bone loss. But in that scenario, if your implant is at 25 Newton centimeters, you can't go back in and unscrew the cover screw and putting healing abutment on it, which is the right thing to do. So you want to save your implant, which means put a healing abutment on it. So therefore bacteria can't get trapped around the top of the implant. But if you do that in the scenario where you have 25 Newton centimeters, you'll back the implant out, right? You'll accidentally unscrew it. So for me and Dune here, I think we both agree that best practices for implants would be a stability of 35 to 45, because you could unscrew that cover screw in that scenario and putting a healing abutment on it. Or you could even, oh my gosh, you could even switch out a multi-unit on the implant. Maybe don't do that, right? But you could, and you're not going to back the implant out by mistake.
Yeah, general rule of thumb, because I know we're coming up on time here, is if you have an opportunity to do a healing abutment, probably consider a healing abutment. You don't need a second stage surgery. You don't need to re-anesthetize the patient. You don't have to worry about your incision not closing over it because the tissue can granulate in around your healing abutment. Maybe a topic for another episode is, types of healing abutments, how we do custom healing abutments, how we talk about maybe immediate load and ways to do emergence profile and tissue management after the surgery. So we can definitely take this a whole lot of different ways. If you guys want to reach out to us at coloradosurgicalinstitute.com, you can find me and Dr. Briskie on Instagram, Facebook, any of the social media platforms, or Dental Success Network. Please give us ideas. We get text messages from people all the time. This topic is actually chosen from a couple of docs who had recurring questions about implant stability. So please reach out with ideas and we can come up with different topics and different segments that we can do and just cover the stuff that's important to you guys. So again, thank you for your attention. I hope you guys have a great Saturday if you're listening to us on the weekend. And if you're listening to us on any other day, I hope you have an awesome day. And we'll report back with another episode next week. And stop. So that kind of ran about 32 minutes. And my guess is you can just run one episode with that one instead of break it up into two. And so for titling, it was the stability and placement of implants in D2, D1, D2, and D3 bone. And then we'll follow back with another episode here soon. Please reach out to us, editors or anyone on Mark's team, if you guys need this done a little bit differently. This is the format that me and Dr. Briskie are going to roll with if we don't hear back from you with any type of points of improvement. And I hope you guys have an awesome day. And then obviously, Dr. Briskie, hope you have a good one. I know you got to run too.
Yep. Sounds good, man.
See ya.